My name is Ian Riley. I'm a professorial fellow at the University of Melbourne, and I'm on the technical advisory group. I've worked on the development of Smart VA, and I've worked on the application of Smart VA in a number of countries, including Solomon Islands, Papua New Guinea, Bangladesh, and a little bit in the Philippines and China. So that's my background. I started using verbal autopsies in the early 1970s. There'd been a series of small population mortality studies in Papua New Guinea. I was asked to develop a site, but I was also testing a pneumococcal vaccine against pneumonia, which was the leading cause of death. But I wanted to get all-cause mortality, and I found there was no standard instrument. And I developed a local instrument for cause of death, and we used that to diagnose pneumonia, and we showed the only effect of the vaccine in reducing mortality was upon the pneumonias. So we proved two things at once. The verbal autopsy instrument worked and the vaccine worked. A verbal autopsy is based on a family experience of the terminal illness of somebody who died, the decedent. There are various ways approaching this. In the old-fashioned way, we got them to tell the story. I'm personally not aware of verbal autopsy refusals. When I was doing research, people would say to me, why are you showing so much interest in this death when you didn't show so much when they were alive? And then we have to say, if we're going to improve the health services, we need to know what people die from and what the problems were. When we started to want to move into the larger arena of CRVS, we realised we needed standardised instruments, and we couldn't use doctors to decipher stories. We needed to have something that could be computer processed. And the one we're using became known as a computer-driven instrument. And the instrument itself, or the analytic method, was based on computer analysis of the symptoms people produced compared with gold standard deaths. A gold standard death was a death in hospital with a very high certainty of diagnosis. We then went to the family and we took a family history, and we got a fixed number of deaths, 100 for each disease, and we looked at the correlations, and we looked at the way that then fed into a computer model. Well, TARIF was the best of a number of methods which emerged from those studies, which were known as empirical studies. The studies took into account the way the family responded to the death, the language the family used, and that sort of thing. TARIF was a fairly simple arithmetic method in which we linked individual symptoms to diseases. So each symptom got a score against a disease. So if we looked, say, at cough, we would get coughs for pneumonia, we'd get coughs for chronic bronchitis, and we'd get coughs for other lung diseases. And then cough got a score for each of those diseases. And then we went through a list of some hundreds of symptoms. When we started to move into civil registration, the instruments which worked very well in research projects were too long. And we then needed to reduce the instrument, and the length of interview went down from about an hour to about 20-25 minutes. And we thought this was then suitable for use in the public arena as opposed to the research arena. Compared with gold standard, TARIF gets the right diagnosis for the individual in about 50% of cases. It gets the right diagnosis at the population level. That will be the percentage of deaths due to a particular disease, the percentage of deaths due to malaria, to lung cancer, to whatever. It gets that right about 80-85% of the time. So the real use for us is the use in telling the top 10, 20 leading causes of death in a country for public health and policy purposes. Compared with clinical medicine, it's a blunt instrument, but compared with clinical medicine, it's very simple. We used verbal autopsies in settings where people die without having had access to a doctor and a medical certificate cannot be written. The gold standard for death is a medical certificate of cause of death, but only about somewhere between 10 and 20-30% of deaths are occurring in hospitals where doctors can write histories. Until the world rectifies that situation, then verbal autopsies are going to have to be the norm. We don't know of any better way of finding out about deaths in communities. We have come to see notification of death to the civil registrar and verbal autopsy as a pair. We cannot rely on families to self-register deaths. There is very little incentive, very little interest. Therefore, we have gone for notification through health services, because health services, one, know about births and deaths should be notified in parallel, and two, have distributed facilities and distributed IT systems, and we've piggybacked onto that. We need to draw a very sharp distinction between the registration of the fact of death and registration of the cause of death. As I said, it's not so sharp an instrument at the individual level, and I personally have concerns when a cause of death from VA gets onto a medical certificate. But a lot of people want this, and this is the sort of compromise that we have to reach. This has also meant, particularly in Papua New Guinea, where the Civil Registration Act has to be reformed, and our colleagues in the Bloomberg have been providing legal advice around the world. So Civil Registration Acts are very often out of date. The New Guinea Act was a 1963 adaptation of a Queensland Act. It has needed to be brought up to date, and we have needed to introduce the concept of verbal autopsy and to get very clear separation between the fact and the cause of death. The recent history is of a shift from the research environment, which I was part of, to the public environment of the civil registration environment. Research, we had trained interviewers who did nothing else. In the public environment, it's been an additional task for health workers. And in some countries, they've been able to have a special cadre of interviewers. In the countries I've worked, notably those three Solomons, Papua New Guinea, Bangladesh, it's been an add-on, as I think it has in China too. So that to collect the history is an additional task, and one of the important things has been to persuade people of the value of this task and how health ministries need more information about the causes of mortality than they've ever had. It's very easy to ask the question, has this new initiative against malaria reduced mortality? But to find out the answer to that question is very difficult. And we're trying to do that with essentially part-time interviewers. So a lot of our effort has gone into training, encouraging people to understand the importance of this, and as I said, to shortening the instrument. Our aim is to have this accepted as the normal part of the health workers' duties. Bangladesh really took off with this, and we ran a pilot study in a sub-district called Kaligonj, and then they were able to replicate those methods very quickly across the country. Papua New Guinea and Solomons are different, and one of the big differences has been the isolation of small populations and the travel time and the trouble we have to take to get out to the villages, and not only villages, people in small homesteads in the mountains, and if somebody dies it's very hard to get there. So we've got a lot of logistic problems in those two countries. The results we're getting are consistent with the global burden of disease results as a generalisation. There are some differences have emerged, and I think they're important. I think the other thing we can do is to start looking at the distribution of causes of death within a country and in different populations. In other words, the data we get is a lot more granular than the burden of disease data, which tends to be national data. but no huge surprises, and we might even be worried about huge surprises because they are blunt instruments. I think sustainability in Bangladesh, Philippines, China is almost a given. I think the small countries have capacity problems which people don't realise, and I think there are some years of work more before we can integrate them into existing systems.